Hello, and welcome to the Sentinel Innovation and Methods Seminar Series. My name is Rishi Desai. I'm an associate professor of medicine at Harvard Medical School and an epidemiologist in the Division of Pharmacoepidemiology at the Brigham and Women's Hospital, and I will be moderating today's session. The US FDA Sentinel system helps address questions related to the safety and effectiveness of medical products. The Innovation Center focuses on developing new methods to further advance Sentinel by leveraging data sources, building new tools, and enhancing real-world evidence capabilities. The Operations Center focuses on supporting the FDA in the use of Sentinel Common Data Model and associated modular programs or tools to gather evidence to support regulatory decision-making. We have launched this webinar series to engage experts and innovators in the key areas to the Innovation Center's master plan and Operations Center's methods work. With that, I'm really pleased to introduce today's speaker, Dr. Josh Smith. Dr. Smith is an assistant professor of biomedical informatics at Vanderbilt University Medical Center. He earned his bachelor's degree in computer science and mathematics from Murray State University, a master's in computer science from the University of Illinois at Urbana-Champaign, and PhD from Vanderbilt. His primary research interests lie at the intersection of data science and patient safety, specifically in using large natural language processing and data mining on unstructured EHR data for pharmacovigilance, knowledge discovery, and clinical decision support. He is a faculty member in the Vanderbilt Center for Improving the Public Health Through Informatics, or CIPHI, and a fellow of American Medical Informatics Association. Dr. Smith has been a part of Sentinel's Innovation Center since its inception, leading multiple projects. He currently serves as the co-lead for the Signal Detection Analytics Board and also has led a number of other projects in addition to what he's presenting today. So for today's presentation, the focus is on a paper that was recently published by Dr. Smith and his colleague titled Data-Driven Phenotyping Algorithm for Acute Health Conditions, Applying PheNorm to COVID-19. Before we get started, I would like to mention that all your lines are muted. If you'd like to pose a question, please type it into the Zoom Q&A feature. We will address all the questions at the end. Finally, we are also recording the session and it will be made available through our webpage, which can be found on the sentinelinitiative.org. Without further ado, I will hand it over to Dr. Smith and thanking him for joining us today to share his project. Yeah.
Great. Thank you, Rishi. And thank you, everyone, for coming. It's a pleasure to be here. This work was performed under a task order from the U.S. Food and Drug Administration, specifically a project under the Sentinel Innovation Center. And the views expressed in this presentation are my own and do not necessarily represent those of the FDA. Like Rishi said, we published this work a few months ago in the Journal of the American Medical Informatics Association. This QR code will take you to the paper if you'd like to dig into it a little bit more. I'll also point out that this paper has a very extensive supplementary materials section with all the details of the different models and methods that we use that I'm going to talk about here. So for those who may not be familiar, Sentinel is the US FDA's active medical products safety surveillance system. Studies in Sentinel utilize electronic healthcare data, mainly in the form of health insurance claims data, but also structured data from electronic health records, or EHRs. The Sentinel Innovation Center, which is a joint effort of researchers at Harvard Pilgrim, Duke University, Vanderbilt University Medical Center, and Kaiser Permanente, Washington, is working to develop, implement, and evaluate methods that use unstructured EHR data. So, for example, free text clinical notes that are part of a patient record. And while there is a significant amount of structured data, such as diagnoses, labs, problem lists, in the EHR, it's been estimated that as much as 80% of EHR data comes in the form of clinical text. One way that we want to use free text notes is to help improve the performance of computable phenotype algorithms, which are used to capture health outcomes relevant to medical product safety surveillance. This project was called Advancing Scalable Natural Language Processing Approaches for Unstructured EHR Data. It began around the same time as the Innovation Center, which also happened to be right around the beginning of the COVID-19 pandemic. While our main goal was and remained investigating ways to integrate unstructured EHR data into Sentinel, we selected a timely phenotype for the work in symptomatic COVID-19 disease. Specifically, we evaluated an automated phenotyping method called PheNorm applied to an acute condition, COVID-19, to investigate its feasibility for rapid phenotyping and use in post-market safety studies. And we'll go into definitions of all these things as we progress. A little more background on what we mean by phenotyping. Phenotyping algorithms are used in healthcare, epidemiological studies, public health surveillance to distinguish between cases and non-cases. So that is, how can you tell if a person has a specific disease or health outcome or not using EHR data? A patient is not necessarily diabetic if they have one diabetes diagnosis code in their potentially decades-long record, or even two diagnosis codes. But if they have several over many years, along with the prescription for insulin and a lot of labs testing their A1C, you can kind of be more certain that they do have the condition. There are many different algorithms that have been developed over the years for many different conditions. Methods range from using ICD codes, multiple ICD codes, or medications or laboratory results to determine if a patient is a true case or not. But these algorithms have typically been developed and validated using time-intensive expert curation and manually annotated gold standard training sets, which often result in high cost, long development times, and limited scalability. Features, variables, and covariates are all ways of saying the same thing. These are the inputs to an algorithm or model that we use to get a desired output. The process of manually selecting and engineering these features are, like I said, both expert intensive and time consuming. First, we must identify potential features using teams of clinicians and informaticians. The knowledge must be reviewed and different structured codes or terms proposed. Next, we need to define our algorithm by reviewing those code lists, assembling a corpus of records, validating code usage, and NLP, natural language processing, if we'll be using that, and specify the logic of our algorithm. And again, this requires a number of both clinical and technical experts. Finally, we have to implement the algorithm, create the NLP output we want to use, perform quality control, and assemble our data sets to train and text our models. This manual development is thus very time and expert intensive and therefore very expensive. But there's another way. Recently, there's been work in the area of what's called automated phenotyping or automated modeling. Whereas manual development is expert driven with manual engineering and a heavy reliance on gold standard labels that requires timely review, time-consuming review. Automated methods can be data-driven. They use automated feature engineering methods and rely on more easily acquired silver standard labels. Automated methods have reduced operator dependence compared to manual methods and can, in theory, be much faster. There are a number of approaches out there for automated phenotyping. AFEP, or automated feature extraction for phenotypes, SAFE, surrogate-assisted feature extraction, and PheNorm are the ones we kind of focused on. All of those methods follow a common set of principles. The first is that clinical text is the primary data source that's used. Second is that published knowledge is what provides the expertise. And three, it's that the feature engineering and modeling that we're doing is data-driven. So automated feature engineering can start out with identifying and defining, just like that manual feature engineering, except we use an informatician to use a tool such as MetaMap Lite, which is an NLP tool here, that recognizes UMLS concepts. Those are concepts about clinical diseases, conditions, symptoms, findings, et cetera. And the tool is then ran on several different clinical knowledge articles. They recommend at least 3. In practice, we use about 5 usually. They can be from different sources. In this example here, it's an article from the Mayo Clinic on COVID-19, Medline Plus article on COVID-19, Medscape, Merck Manual, and even the Wikipedia article from COVID-19. MetaMap processes each one of these data sources and identifies all of the different symptoms, concepts, diseases that are mentioned in the articles. If concepts are found in the majority of articles, so at least 3 out of 5, we include those as features for our model. And we usually end up with 100 to 300 when you do it this way, depending on the disease. You can then use a clinical expert, if this is not a required step, but recommended, to remove any non-specific concepts. So concepts that show up in all the articles, but that are really not related to disease. What this gives you is what we call a data dictionary. These are the features that you can use to predict the outcome that you're interested in. For implementation, we would then also use a tool such as MetaMap or MetaMap Lite, which is what we use in this project, to process patient charts. The features we are extracting are counts of each one of those concepts or terms that occur. So for each patient, you have a list of 100 to 300 concepts and a count of how frequently they occur in some specified time window. As you can see here, the number of clinicians and informaticians that you need to implement an automated approach is significantly reduced. Automation can provide us with shorter development times, lower expenditure for domain expertise because we rely on the published material for that expertise, reduced operator dependence since one side implementing this automated approach should, when using the same data, end up with the same algorithm. And therefore, it can also be more replicable. But there was a question as to will it work? Can this be a starting point to improve speed and reduce cost of phenotyping? Can this be a complete solution? Automated approaches like this have been shown to work with chronic conditions. With chronic conditions, diabetes, like I mentioned earlier, usually have years of data, dozens of chances to recognize the disease, multiple visits, multiple codes, prescriptions that can be recognized as being related to the condition. But an acute condition, by its very nature, has a briefer window where the data can be recorded and recognized within the longitudinal health record. So we wanted to see if this approach would work on an acute health condition. PheNorm, the method we use, was developed by you and colleagues. Like I said, it's been demonstrated to perform well outside Sentinel for chronic health conditions, but little was known about its performance on acute condition. PheNorm is a general purpose approach, an automated approach to creating computable phenotypes. It's based on natural language processing of clinical notes and machine learning. PheNorm also estimates the probability of each patient's being a true case, having the disease, using what we call silver standard labels, which are readily approximations for true case status. And it also uses the NLP-derived features that we extract from clinical notes. Silver standard labels can be something like ICD codes, something that's already present that might not be perfect in recognizing the disease, but that provides an initial starting point. You see here in this figure, the PheNorm algorithm as we've distilled it. This was created by David Carroll, my co-lead on this project. First of all, you select the phenotype that you want to use, in this case, COVID-19, and specify the definitions. We first define a filter to select patients and events and bring them into our cohort. This can be some sort of simple inclusion criteria like age, or it can be more complicated. We then define our silver standard labels. What are we going to use as approximations for case status? And then we also define a data catchment window for the silver labels and NLP features. That is, what time period are we starting from, and what are the boundaries on which clinical notes we will use and which structured data we will use from the EHR. Next, you take those filters to assemble the cohort and use the silver standard labels to assemble the silver standard data. And then you assemble also demographic data for all the patients in the cohort, and that gets put into your modeling data set. At the same time, we will also mine those clinical concepts from the knowledge base articles that I showed you earlier to create our data dictionary, our features that we're going to use to predict the disease. We then assemble the final corpus, extract the features using NLP, and we have our modeling data set. As a side process, we also want to evaluate the performance here. And so while we don't need gold standard data for PheNorm to create our model, if we want to evaluate how well it's performing, we do need some gold standard data. So we take a sample and we also do manual chart review to find out if the patient has the disease or not. After we build our model, we will then evaluate it against the results. Another step that's optional is what's called dimension reduction. We'll do this in our project. We take all of our data with all of our features, and then some of those features might not be very informative by themselves, or some of them might be kind of superseded by other features. So if this term shows up, it always shows up with this other term. Dimension reduction allows us to reduce the number of features while hopefully retaining performance. Finally, we train the PheNorm model based upon all our training data and the modeling data set. We then select a cut point of probability. So is a score above 50% means the patient has the disease, a score below means they don't. We can choose a different threshold depending on if we want to maximize sensitivity or positive predictive value, for example. And then our final step is to evaluate that performance with our gold standard data that we set aside. Coronavirus disease 2019, I'm sure you're all familiar, unfortunately, with that. Was first identified December 2019. During the pandemic, diagnostic guidelines, lab tests, coding practices, and treatment options changed rapidly, especially at the beginning. So we developed a phenotyping algorithm for COVID-19. This was motivated partly by the fact that some research showed that diagnostic codes for COVID-19 were shown to have low accuracy. That may have been due to both overcoding and undercoding. Providers may have been more likely to diagnose a patient with COVID-19 due to administrative reasons at certain times, or high incidence rate, or tendency to label conditions with similar symptoms. Conversely, mild cases might have been undercoded during this time when some healthcare resources were stretched thin and when patients with mild symptoms were discouraged from seeking care in some places. In either case, patients with positive PCR tests were often coded correctly for COVID-19, even when asymptomatic. But our focus here was on symptomatic COVID-19 disease. So evidence of infection was insufficient since many patients who tested positive for COVID-19 were asymptomatic. And we defined symptomatic COVID-19 infection by at least mild symptoms as characterized by the National Institutes of Health. And I'll go into detail about that in a few minutes. The study was performed at Vanderbilt University Medical Center in Kaiser Permanente, Washington. We first identified cohorts of potential COVID-19 patients from April 2020 through March 2021 at each site, so 1 year of data early in the pandemic. Cohorts included all patients with encounters accompanied by structured EHR data that were found to be strongly associated with COVID-19. This included 6 ICD codes that were directly related to COVID-19. I think there were 2 for COVID-19, and there were some others for like COVID pneumonia or other complications of COVID-19. And then we also used 43 other codes, diagnosis codes, problem list entries, procedures, medications, labs, that were found to be strongly associated and occurring with COVID-19 diagnosis. This kind of had the added benefit to ensure that we not only had true cases in our sample, but we also had controls with no disease, and that those controls would kind of look more similar to true cases. The VUMC cohort consisted of both inpatient and outpatient counters, and the KP Washington cohort consisted of outpatient only. In PheNorm, also a fixed date catchment period that's anchored to the patient-specific index date is used to identify and operationalize those silver labels and features. The earliest encounter for each patient with structured evidence of COVID-19 disease was used. So if they had a diagnosis code, that was their index date. If they had some of those other features when they first appeared, that was considered their index date. Our catchment period was the index date plus or minus 30 days. So we included all the patient's notes and structured data from 30 days before their index date through 30 days after their index date. It was unlikely that they would have relevant information before their index date, but we included that as well, just in case, so we didn't miss any relevant data. Eligible patients included adults age 18 and older with at least one encounter that had at least 1,000 characters of clinical text, which was necessary since clinical text was our main input to the algorithm. As I mentioned before, PheNorm replaces gold standard data, which is scarce and costly, with silver standard data that it uses during modeling. Silver labels are imperfect, like I said. They don't exactly correspond to true case status, but they can be close. And the PheNorm method suggests considering multiple alternate versions of silver labels to see which ones work best. We therefore used information from each patient's data catchment period to operationalize 4 different silver standard labels that either use just structured data or NLP-derived data. Structured label 1 was a count of the calendar days with a COVID-19 diagnosis. UO7.1 is the diagnosis code, including both outpatient visits and inpatient days. Structured label 2 was a count of calendar days with any of 6 of those COVID-related diagnosis codes, which includes UO7.1 as well as the other codes of related conditions that mention COVID-19. And then we had 2 NLP silver labels. NLP label 1 was a count of the number of mentions of the term COVID-19 in their chart notes. And NLP label 2 was a count of chart notes with the concept for COVID-19 disease. The UMLS contains a lot of clinical concepts, and those concepts can range from like fever or can to diabetes, so kind of symptoms, diseases, and it has a number of synonyms for each one of these things. So we included COVID-19 disease concept from UMLS because it would capture more than just the term COVID-19. The machine learning models use features, also called variables or covariates, as inputs to produce an output, which is based upon training data. The input features are usually based on structured data, such as diagnosis codes or laboratory values. But PheNorm's primary features are NLP extracted clinical concepts, the ones that are mentioned in the unstructured text of clinical notes that we capture using NLP tools. We processed all these clinical notes within a patient's catchment window, that 30 days around their index date, using a tool called MetaMap Lite, which is available from the National Library of Medicine. And like I said, PheNorm primarily uses structured or NLP extracted data as input, but they also suggest using structured data if it's also informative. We kind of limited our structured data. We only included 2 structured data features. That was patient sex as captured in the EHR and patient age in years. If you were to extract, say, all the clinical concepts mentioned in patient notes, that's a very large feature space. There's a lot of concepts that are probably not informative to your outcome of interest. Like most phenotyping algorithms, PheNorm limits the input features to those that are relevant. And as described earlier, we utilize the AFEPT, or automated feature extraction for phenotypes approach, to define a dictionary of relevant concepts. As I said, we used 5 clinical knowledge base articles on COVID-19 from the Mayo Clinic, Medline Plus, Medscape, the Merck Manual, and Wikipedia. They were all processed using the MetaMap Lite NLP tool, and we identified 295 candidate UMLS concepts, or CUIs, that appeared in greater than 3 articles. We did use a physician reviewer to remove any concepts that appeared to be nonspecific or unrelated to the disease, and ended up retaining 158 CUIs, concept unique identifiers, in this dictionary after that manual review. So those are going to be our features on which we would predict if a patient had symptomatic COVID-19 disease or not. In addition to those NLP features, well, let me go back. The NLP features for PheNorm are basically counts of mentions of the clinical concept within the note, so within the catchment window. However, there are additional options that can be considered. If the note says the patient had no fever, fever is a clinical concept, it is present, we would count that. But if we took negation into account, the fact that the physician said no fever in their note would mean we shouldn't count that. It's a negated word. According to the developers of PheNorm, they found that using negation wasn't really necessary, that they still got good results without the use of negation. So we weren't sure if we should include it or not. We considered that one of our feature engineering options. So we did create features that ignored negation, and then we also created features that use negation, considered whether a term was negated or not. Another feature engineering option we tested was normalization. Longer notes have more concepts, and so more information is potentially useful, but it could also be misleading. So we normalize based on the length of the note. Finally, there's also dimension reduction was our third feature engineering options. The idea being that we could get simpler models without sacrificing performance by removing those duplicative or less informative features from consideration. When those large number of features are available for a model or training, and the number of observations available are limited, we can see why certain things might be useful and certain things might not be. These are the 5 model sets that we focused on, and each one had an associated scientific question. So we decided the first one, model set 1, is that we would ignore negation, we would not normalize the patient's chart, and we would not do dimension reduction. So do we need any of these feature engineering options, or can we go with the simplest approach, just counts of the concepts in patients' clinical notes? For feature set 2, we tested it just using negation. For feature set 3, we tested it just using normalization. And for feature set 4, we just used dimension reduction as the only change from the base set. And then finally, in feature set 5, we included all those options. We also tested the other 3 logical combinations of this, where 2 were on and 1 was off. What this resulted in were 8 model sets for each of our 5 PheNorm models. We had 5 PheNorm models because we had 4 silver labels, 1 for each of the 4 silver labels. A 5th aggregate model, which was the average of the predicted probabilities from the 4 silver labels. And that's a total of 40 models. We trained these models using data from patients without gold standard data, and evaluated the models using that data from that set-aside sample with gold standard labels. As I've said, I think several times, PheNorm uses those silver labels for training, but we do need gold standard data for evaluation. We used manual chart review to create the gold standard data used to evaluate our PheNorm model from a stratified random sample of patients. Trained chart abstractors, following written guidelines, assigned phenotype positive labels to the patients with evidence of at least possible SARS-CoV-2 infection and at least symptomatic COVID-19 disease. And then phenotype negative labels to all other patients. Our inter-rater agreement was assessed using 2 reviewers at each site. Here we have on the left our evidence of COVID-19 infection. So we classified things as definite or highly probable infection, probable or possible infection, unlikely infection, not infection, or insufficient information. We have a severity of illness scale on the right from the NIH. Say, for example, green, if they had any of those concepts mentioned in green, like fever, cough, sore throat, that would count as a mild case. If they had any of the symptoms for the other levels, we would count it as moderate, severe, or critical. But the important thing for our study was at least mild illness and probable or possible evidence of infection. The results. So at VMC, our cohort consisted of 24,177 patients, and those patients had approximately 1.1 million nodes in their catchment windows, which is that plus or minus 30 days around the index date. At KP Washington, they had 8,329 patients and approximately 143,000 nodes. Our gold standard evaluation samples each site, we had about 419 patients at UMC, 437 patients at KP Washington that we were able to review. And inter-rater agreement was fairly high for both sites. We had a Cohen's cap of 0.95 at VUMC and 0.8 at KP Washington. The characteristics of our study cohorts were fairly similar at both places. About 58% female at both sites, 23% age 18 to 29 at VUMC versus 13% at KP Washington. About 30% at both sites were between 30 and 49, and then there were slightly more patients over the age of 70 years at KP Washington compared to Vanderbilt. 68% white at VUMC versus 64% at KP Washington, and 9% Hispanic ethnicity at KP Washington compared to 4% at Vanderbilt. In terms of results, the AUCs, or area under the curve, across all PheNorm models range from 0.77 to 0.8 at VUMC and 0.8 to 0.85 at KP Washington. The positive predictive value for the models at the maximum F1 score ranged from 0.858 to 0.903 at VUMC and 0.772 to 0.876. If you're not familiar with F1 score, it is the harmonic mean between positive predictive value and sensitivity. It's kind of a way of balancing the two. And so we kind of measured what our performance was at the point that maximized that F1 score. The VUMC model with the highest AUC was trained on structured label 2, that is those 6 ICD codes that indicated COVID-19. And it also didn't pay attention to negation or use feature normalization or dimension reduction. The highest AUC KP Washington model was also trained on a structured label, but structured label 1 gave them the best performance. That was just the US7.1 COVID-19 diagnosis code, but with feature normalization and ignoring negated mentions and dimension reduction. To show this in a more structured way, these are again the best performing model sets at each site when maximizing that F1 score. So VUMC model set 1, we see here structured label 2 had the highest AUC. And so at that cut point in the model that maximizes F1, we have a 0.976 sensitivity and a 0.885 positive predictive value. If we want to look at where F1 is maximized instead of the highest AUC, we see that performance is also very good, 98% sensitivity, 89.6% positive predictive value. KP Washington, for their model with the highest AUC, again with structure label 1, that's at 80.853 area under the curve, 88% sensitivity and 85% positive predictive value. And the performance at the maximum F1 was from an NLP silver label, and that had 95% sensitivity and 80% PPV. Another way to look at these results are using these graphs here. So for example, this is the model performance at VUMC on modeled set 1 for that structured silver label number 2. You see here sensitivity in red, PPV in green, for example. And along the bottom of this chart is our percent cutoff. It's basically a score threshold where you say everything above this is true, everything below this is false. And you kind of use it by taking the percent, 90%. Let's say we want a 90% PPV. And so we cross the model at that 90% line, and then we look at where the sensitivity is there. And so at this point right here, as you can see, this is where PPV and sensitivity are balanced. And that's a PPV of 90% when sensitivity is 90%. If we use a cutoff that is about 0.23 or 0.24 down here at the bottom. So that's very good performance for one of these models. At KP Washington, performance was a little bit different, but it was very similar in terms of how the graphs look. If you do 80% PPV, that gives you a 90% sensitivity on this graph. So at the 80% mark, wherever PPV achieves 80%, sensitivity is 90%. And if you wanted 90% PPV, that would give you a 75% sensitivity. So sensitivity drops as PPV increases, which is the relationship we would expect. Both sites performed very well. Model transportability was another question we had. So in addition to testing local models on local data, we also tested each other's models on our own local data. So VUMC shared their model with KP Washington, who ran it on their data, and vice versa. And it produced surprisingly good results. So as you see here, VUMC models on VUMC data are in orange, and the KP Washington models actually perform better on our data than our own locally trained models. Only a little bit, might not be significant, but the performance is very good, showing that it's transportable. If we look here, this is the animation was kind of subtle there, but this is KP Washington's model on their own data in blue, and VUMC model on KP Washington data in orange. And the performance there was also very good. We're not exactly sure why here on the right, the performance is not as good on model set 5, but that did include negation and dimension reduction and normalization. But all the other ones performed very well. And in some cases at VUMC, like I said, the model from KP Washington performed better. These results, they varied by performance, or the model performance varied by silver label, but the models trained on structured data labels generally had higher AUC at both sites. This is a good thing because it's easy to get those structured silver labels. Just using the ICD code had higher AUC. It resulted in better performance. We didn't have to run the NLP first and come up with an NLP-based silver label, like counting a certain number of words or terms or concepts. Performance also varied when using those different alternate feature engineering options, but they all yielded strong performance. And it turned out that excluding the negated mentions or normalizing feature counts actually had fairly little impact on model performance. And dimension reduction produced models with strong performance based on fewer features. So that means those models were simpler because they had less features in them and were therefore probably easier to implement at other sites. Overall, the changes and additions only minorly affected performance, and that baseline model, without any additional feature engineering options, using a silver label based on existing structured data, performed almost or just as well as the other slightly more complicated models. Using cut points of model predicted probability that yielded greater than or equal to 80% PPV, which is kind of a commonly used benchmark in these studies. For 80% PPV, we got sensitivities of 0.99 in the best VUMC model and 0.905 in the best KP Washington models. So at both sites, we were able to achieve a usable model. Performance metrics and levels suitable for addressing different specific scientific questions can be achieved by selecting a different cut point. So if we cared more about sensitivity in this case or more about PPV, we could adjust that cut point to decide where we wanted to use the model at. That does come with a caveat that you do need some amount of gold standard data for that evaluation process and for determining what the best cut point is. But not as much gold standard data as if you were training on the gold standard data as well. Also important to point out, at both study sites, the performance of the externally trained models was generally similar to those of internally trained models. The AUC of the best externally trained model at VUMC was 0.804 compared to 0.817 for the best locally trained model. And at KP Washington, the best performing externally trained model was 0.834 compared to one of 0.853 for the best locally trained model. So at both sites, both models seem to work well, which seems to bode well for the transportability of this approach, at least for this phenotype. So we don't know for sure about all other phenotypes. We know that this phenotype works well, and we should probably test it with some other ones. There are some limitations to our study. First, and probably most obviously, we use data from early in the COVID-19 pandemic, which can introduce idiosyncrasies that are relative to other phenotypes and time periods. COVID-19 was different. No one had seen it before. It was a new thing. Healthcare systems were kind of inundated at the time. So the data may show that in some ways that we're not preparing for. We also use data only from 2 healthcare settings, which even though they were diverse, they may not be representative of other settings. As you saw, our demographics were fairly close, but it's also interesting to note that VUMC included inpatient and outpatient data, while the KP Washington model only included outpatient data, and their models performed even better than some of our local models on VUMC data. More work, however, still needs to be done to assess the performance on other acute phenotypes. Oh, and I should also mention that the positive predictive value of the COVID-19 ICD-9 code, as I showed earlier, there was research saying it was not very good, especially early in the pandemic. But it turned out the ICD code's positive predictive value at Vanderbilt was actually better than expected. But still, we were able to get improvement in performance by using PheNorm. And at KP Washington, the PPV was as expected, not great for the ICD code alone, but they showed significant improvement over that using PheNorm. In conclusion, the PheNorm approach can successfully identify an acute health condition, COVID-19 disease. Tools such as PheNorm that utilize unstructured EHR data can support rapid phenotyping for public health surveillance. It uses far fewer people, takes far less time, and therefore less cost. Preliminary results indicate models trained at one site may be transportable to other sites with little decrease in performance. And the simplicity of the PheNorm approach allows it to be applied at multiple study sites with substantially reduced overhead compared to traditional phenotyping. As I said, we need to test in other phenotypes. We have begun preliminary work in doing that. We've actually finished testing it for anaphylaxis. This work hasn't been peer-reviewed yet, so take it with a grain of salt. But we have found very good results in using PheNorm to identify anaphylaxis. And we look forward to publishing that shortly. So we do believe this has potential for use with not just the chronic conditions that it's already been used in, but with acute conditions for rapid phenotyping for safety surveillance. I'd like to acknowledge the support of the FDA Sentinel Initiative and the FDA Sentinel Innovation Center, our team here at Vanderbilt University, and in particular, well, everyone in particular. Also, the team at Kaiser Permanente Washington Health Research Institute, David S. Carroll, who was my work group lead on this project. And I'd also like to thank the Sentinel Innovation Center work group for their support on this project as well. Thank you all for coming. I'm happy to take any questions.
Thank you, Josh. That was a really awesome overview of your work over the last few years. So really appreciate that. So for folks, this is just a reminder, people can check, your lines are muted, so you have to type in your questions. So please do that in the Q&A box, and then we can read it out for you. All right, so we already have one question posted anonymously. The question says, how does the performance change between the height of the pandemic versus now, Josh? Because there is a different prior, obviously, of having COVID. And the question also extends to ask about, can the model distinguish between similar conditions like RSV or flu or other infections?
We haven't tried to rerun it on more recent data, so I can't tell you for sure how well it would work. What we did find, there was a lot of variability in the data early in the pandemic, even compared to like April of 2020 and March of 2021. So I would imagine the way people talk about it, the terms that are used, the concepts that are mentioned in the notes have kind of settled into some sort of equilibrium now. And so I would expect a little bit better performance in terms of that. We have done a little bit of work on trying to recognize different levels of severity of COVID-19, which did not work as well. So it's actually, like I showed you that NIH scale of like what's considered mild disease, what's considered moderate disease. The difference between mild and asymptomatic is a lot. There are symptoms versus there are not. But the line at which we draw the difference between, say, severe and critical is a little bit fuzzier, and so it's hard to tell. I do believe that for other things like flu and RSV, you might have similar performance as COVID-19. The symptoms of COVID-19 are kind of all over the place compared to a lot of diseases that we're more familiar with. So my guess is that it would perform a little bit better in those cases, but I don't know if we have strong motivation for that or not, because I'm not sure if the diagnosis codes for flu or RSV have a low predictive value like the one for COVID-19 did early on in the pandemic.
Yeah, I think, Josh. So we also have other questions rolling in as well. So one of the questions asks, if you wanted to use this in languages that are not English, for example, Spanish, something like that, uh, can you use these types of methods to do that?
Absolutely. I mean, I personally haven't used MetaMap Lite for non-English text before, but I know the UMLS has, for example, Spanish language vocabularies and terminologies in it. We used, I think, SNOMED CT is our main terminology, but there is Spanish SNOMED CT. In the later work we did on anaphylaxis that I briefly mentioned, we use MEDRA, which I think also has different languages in it. So in those cases, you would need a Spanish language knowledge base articles on the disease, which you could easily find. You would need to set your NLP tool to vocabulary that use Spanish language, and you would learn your features that way. And then I assume you would use notes also in the Spanish language to extract the same concepts. You probably could even use, since UMLS like connects concepts in different vocabularies, the concept ID for a disease in English is the same as the one in Spanish. So you could even use a different language for your notes as for your knowledge that you're learning too. But yeah, I don't think that would be a problem at all.
Okay,
Depending on performance of the NLP and the other language, which I know can be variable.
Database central, yes. So Sebastian has a few questions, so I will read them out one at a time. So he asks if structured information is was driving the result in this example. Can you imagine other use cases where unstructured information is more important?
Well, the structured information was driving the fact of infection, but not the level of symptoms, right? And like I said, everyone who had a positive PCR test did have COVID-19, but a lot of those people were asymptomatic as well. So I think a lot of the information actually was in the NLP here. Anaphylaxis, another example. The positive predictive value of the ICD code for anaphylaxis is known to be fairly poor. And we've had a lot of studies that have worked on writing algorithms to try to identify true cases of anaphylaxis or not. So I think in that instance where we have, like I said, it's not published yet, but where we have found success in identifying anaphylaxis using the NLP, I think that information, or at least the details of it, are what's in the text of the notes. I'm not sure, like, I know there are a lot of examples of ICD codes that don't work super well for identifying like true positive cases.
Yeah,
and I think what
a good example, right? Because there is a lot of problems differentiating between the causes when you're interested in drug induced versus food induced or something.
Yeah, but I think like if the ICD code, I mean, from our experience, if the ICD code is okay, it works as a silver label, and the NLP provides that additional detail you need to kind of tease out the truth.
So the other question here that he asks is actually really something that I was wondering as well, which is that in optimal circumstances, when you have all the data infrastructure ready, investigators ready to go, how long would it take to work through this pipeline from asking the question to deriving the performance metrics?
I mean, that's a good question that I probably should have thought through before being here. We did these in kind of a research thing where we tested each step and had to decide on different concepts and review different knowledge sources that we were going to use. But if you had a set of knowledge sources that you'd pick out and you had NLP staff who could run them, I feel like a couple months might be sufficient to process everything, if not faster than that once you got going. But a lot of it is processing time if you set up a pipeline to run through this, and that's not really very long. We use MetaMap as a tool, MetaMap and MetaMap Lite, but large language model methods that also map to UMLS concepts could also be used in this, which are also quick and which might produce even better results by improving that input from those steps in the pipeline.
Great points. So final question from him is, so it's useful for purposes of Sentinel to focus on acute conditions, right? Because the outcomes are such for medications that we are interested in. So that comes along with a challenge though, because you need to nail down the onset of something. So how did you deal with that? I guess, how did you consider
I mean,
that?
that's a difficult thing. Like I said, for for chronic conditions, you have data over years. And if you're reviewing the medical record in an automated method, you have 100 chances to catch that a person has diabetes from all the different evidence. But for COVID-19, we needed an individual time to pick as an index date. And we used ICD code if there was one, or we used these 43 different procedure codes, diagnosis codes that we found to co-occur much more frequently with COVID-19. So that's one way to do it. We published a poster on that a few years ago at ISPE. We called it our high sensitivity filter. So it's kind of a way to capture additional structured information that might be related to a condition of interest. It does purport identify a lot of false positives, but that's not a bad thing when you're training this model because you want examples of controls as well as cases. But it's difficult because if you're doing that with anaphylaxis, for example, you do need that ICD code as well to kind of identify it, or you need other things like we looked at procedure codes that patients had, or if they were given epinephrine, that was considered possibly an index date situation. So that's the rub. Like, where do we decide the index date? And it's important. So I think with many more diseases where we try that out.
Yeah, I have a follow-up on that. So in your gold standard label creation, did you also extract information related to how reliable the timing of event was by the manual reviewers?
The reviewers only got to look at notes around that index date. So even, but they could see 30 days before and after. So even if it was wrong, the input that goes into the model is that whole 60-day chunk. So if it came at the end, that was no different than if it came earlier than we identified it as well. But to your point, like the size of the catchment window can matter because we could miss it for that patient because we picked the wrong size of catchment window or the wrong index date.
Yeah. Okay, this is all very helpful. Thank you, Josh, for entertaining these questions. There was another question posted anonymously asking if you used any basic or simple algorithm like a keyword match as a baseline to PheNorm.
We used a keyword match, I think, in one of our experiments where we identified like COVID-19 mentions or later for anaphylaxis, like mentions of epinephrine. So those were just the keywords. But we did not try that with like generating the AFEP dictionary of concepts. We used the UMLS because it identifies a synonymy to try to find that. A lot of times, even words that are are very similar can have differences in like how they're spelled or space in a certain place. And just doing a direct keyword match probably wouldn't catch those. So the NLP tools kind of are more robust in that way, and that they can identify the repetition and how frequent the terms show up and things like that. So I would recommend using an NLP tool, and something like MetaMap is actually fairly easy to apply to things and catches that synonymy. But no, we didn't actually test that on most things.
Okay, great. And there were a couple of questions posted in the chat. I'll read them out. There was one question about any information that you can provide on the actual features that turned out to be important, like the ICD code, for example, or the terms, NLP terms in the model itself.
I can't off the top of my head, but if you look at the paper, it does have information on like feature importance where we extracted the importance of certain features in there. I think that's in the supplementary material, if not mentioned in the main text. But it was terms you might imagine, like COVID-19 is important, but also like major symptoms that showed up a lot were important. Yeah, and then whenever we applied that dimension reduction step where we removed certain features that weren't very informative or that were correlated strongly with other features that were kept, you can see which ones that the algorithm thought was more important there by which ones that kept. And so there's more information on that in there, but it's kind of what you would expect, the terms that show up. You're like, oh yeah, that makes sense that those are important. They definitely pass like face validity when you look at them.
Okay, great. There's one more question about any thoughts on why the negation or normalization not improving the performance?
So I thought it would improve dramatically. I was very surprised that it didn't work. Negation is an important problem, and especially in clinical text. I can understand why negation is not important for the AFEP dictionary step, which is where you just want to know all the concepts that are related to the disease. It doesn't matter at that point if they need to be negative or need to be affirmed, right? It just matters that that's related to the disease. And so the algorithm will learn whether they need to be there or not need to be there. My theory is that affirmative terms were mentioned more often than negated terms, and that the negation that standard and MetaMap didn't work super great. Like, I think maybe that if the negation was working really well, then the negation, then incorporating that into the prediction would have mattered and it shown improvement. But if the negation doesn't work very well, then it might as well be turned off because it's not giving you a big difference. Clinical notes are pretty complicated in structure and syntax, and so it's hard to tell when something's negated. It's a difficult problem. And we just used kind of the out-of-the-box negation detection. It didn't tailor it to our local sites. My theory is that if you did that, it probably would improve performance.
Okay, so I think that that's all the questions that we have received. I really enjoyed this talk, Josh, and your leadership on the project. So congrats on the elegant fork, and thank you for presenting this today. Do you have any parting thoughts before we wrap up?
No, but I look forward to trying some more phenotypes and maybe hopefully using it to improve safety surveillance by increasing the speed of phenotyping. So thank you, everyone.
All right, excellent. So before we wrap up, just a quick reminder that the session is recorded, will be made available on our website. You can also find details and registrations for future talks on our website. So this concludes our session, and we will hope to see you again next month. Thanks, everybody, for joining.